It's another busy day in the practice. You're seeing several patients an hour, or maybe you're on the surgery roster. The word anatomy probably never enters your mind, even though you're using it all the time, examining patients, performing procedures, interpreting diagnostic images. But how does that world connect back to anatomy class at uni? If you had the chance, what would you tell your younger self? And is there opportunity to incorporate anatomy more mindfully into everyday practice? I talked to veterinarian Dr. Anne Quain to find out. Welcome to the very first episode of Veterinary Anatomy in Practice. I'm Corinna, and I'm joined today by Dr. Anne Quain. Anne is a lady of many talents. She is a companion animal vet. She's a veterinary journalist and ethicist, co-author of the book Veterinary Ethics, Navigating Tough Cases. She's a university lecturer, researcher, teacher, mentor, and yet she has somehow still found time to be with us today. And that's lucky for us. Welcome, Anne.
Thanks. It's so wonderful to be here and such an honor, and a little bit confusing because I'm not brilliant at anatomy. So I'm just going to put that on the table right at the beginning.
Perfect. It's all good. That's exactly what I was looking for.
Well, you found the right person.
Before I dive in, I just want to check, have I left anything out of your bio? Is there anything else you'd like to share with us today about yourself?
Oh, gosh. Well, no, I just finished my PhD, and I tell everyone who will listen that I just finished because that's been a very big journey. It took a while. So for anyone out there who's doing a PhD, it will happen. It'll come together, but it doesn't feel like it for about 5 years.
Well, that's the first piece of great advice that you've given us today. So thank you very much. Okay. So to start off, I'm going to ask you to cast your mind back. I'm not going to ask you to tell us how many years, but I'm going to ask you to cast your mind back to university days. And I'm hoping you're going to tell us a little bit about what it was like, or what you can remember of learning anatomy, and maybe some of the feelings that come up for you in reflecting back on those experiences.
Yeah, sure. Very good question. I was really excited to begin studying anatomy because it was the first non-lecture activity that we were having, our very first practical. Right. It was our first opportunity to have our hands on animals. And so I suppose for me as a lifelong animal lover, it was a really different way of seeing animals because I'd been used to thinking of animals as whole creatures, but suddenly we were being asked to look at the components of an animal, which was a totally different way of looking at them. We had a teacher at the time who's now deceased, and I won't name them, but they were really, unfortunately, very intimidating. I think they felt like teaching was a bit of a game, and the reason I mention that is because I think it had a really terrible impact on me, actually. Suddenly, instead of being really curious about anatomy, I was filled with anxiety and dread. So instead of being taught, you're going to learn this because it's the basis of surgery and physical examination and your clinical work, and it's biologically interesting and all of that sort of stuff, it was very much put to us like, there's a huge volume of information, you're going to have to get through this, a lot of people will fail, and no attempt to really insert the why, no attempt to contextualize this learning. So I found anatomy terrifying, as did quite a few of those in my cohort. We were told the way to learn it is just make a big table and note the I think we started our first practice on muscle. So note the name of the muscle, the origin, the insertion, and when you're confronted with this much information, it just becomes this really meaningless exercise in rote learning. So I found that difficult. The other thing about this example, this teacher, was they had a reputation for putting trick questions in exams. And so, you couldn't win. There was no sense of control or progress. And If I can say anything to anyone who's a teacher, just remember that you can make a huge impact, a lifelong impact on your students. So I feel like I had quite a negative experience.
Thank you for sharing and being, so opening up like that, the way you have. I think that's really brave, and it's really great to hear how that has shaped your experience, and to think about how we might approach anatomy differently to change that. And I think a lot of teachers do it differently. So
yes. There are great anatomy teachers out there. It's just that the very introduction that I had was set me up. It was such an aversive experience. It really was quite memorably negative, to the point where when I subsequently had better teachers, I still felt a real mental block around anatomy. I didn't have that curiosity because it was dominated by anxiety.
Wow. Okay, that's so interesting, because when I taught anatomy, it was a revelation about how amazing this subject was and could be. And I think that's when I first realized that I had probably gone through something similar to you, that it was just overload and shut down. So, and that's what I'd really like to unpack a little bit more. So as you moved forward towards your clinical years and towards graduation and into those early years in practice, what happened to that information from anatomy classes? Did at least some of it find its way into a toolkit that you took through to day one practice and beyond?
Honestly, I think very little of it stuck because I was so stressed about it. I did just enough to survive the exams, and that was the ethos that this teacher also promoted as well. You've got to get through these exams. I tell people that I struggled and I kicked and screamed through the first 3 years of my veterinary degree. And I also think that the reason I share that is because it's not an easy degree for everyone. I'd come from a background as being an art student. So I'd studied philosophy, where you questioned everything. It wasn't about rote learning. It was all about analysis and exploration and curiosity and following threads to dead ends, but for the joy of just exploring things. So getting to a degree where the very first lecture I was told by this particular person, it's all about rote learning, you've got to pass your exams, and don't question anything, was a real culture shock. And I reckon it took me about 3 years to kind of adjust. But by that stage, when we started to turn to clinical work, I realized that I was a very experiential learner. I was an emotive learner. If I had a reason to learn something, I could learn something. So when we really focused on clinical cases and the stories behind those, the history of the animal, the history of their relationship with the owner and the clinical signs they had, everything started to make sense to me. And actually I had another lecturer who was quite different. And you might remember Henry Collins, parasitology lecturer. I wasn't a star in parasitology either, but when I explained to him my sort of challenges and why I'd found that, my clinical years were easier, and it was actually just after I graduated. And then when I graduated, I really hit my learning in a big way. Henry said to me, "Oh, yes, vet school's wasted on vet students because you don't have that context in which to place those little fragments of knowledge. So you often end up with this big pile that's quite hard to sort through." And for me, as soon as I started my clinical placements, I suddenly had stories to insert those facts and bits of information into, and that made all the difference. It really did change things for me. So if you're a student and you're struggling in the preclinical years, I don't lose hope. It was so worth hanging in there. But I'm glad I was able to shift gears because it wasn't a fun way to learn either.
Oh, wow. You're just prompting two memories for me that so powerfully. One is Henry Collins saying or teaching me that lice are very precise, meaning that each species of animal has its own species of louse.
That's great.
I remember that decades later.
Yeah.
And also Professor Peter Doherty, who's a veterinarian, of course, very famous Nobel laureate, saying that that veterinary science is the best applied biology course in the world.
Yeah.
And that's definitely, I would agree with that. But it does mean that you have to go through that process that you described of being able to contextualize into the clinical environment all of those fragments of information that come together to make such an important whole.
Yes.
So, fascinating. Okay, so let's fast forward to today.
Yeah.
Do you mind starting by describing what everyday clinical life looks for you? Like, say, just give us a description of what of an average working week, what that involves in veterinary.
Yeah, so absolutely. I go into work and the first thing I do is a patient check. So I screen and make sure that everyone's alive, they're okay, their drips are running, that their drips are in. Sometimes the animal has removed the drip by themselves overnight or taken the e-collar off or removed the urinary catheter. So you've got to
Bit of
check
maintenance.
those things, all the maintenance things. And then I look at my schedule and see what's coming in. And look, in veterinary general practice in inner Sydney, that's often a mix of vomiting, diarrhea is very, very common. Urinary tract obstruction in cats is really common. Otitis externa. Usually someone will book in a patient with a sore eye, and that could be anything from, a cherry eye to a corneal ulcer. Corneal ulcers are very common, or it might even be Horner's syndrome. So we see all of those kinds of things. People might, the appointment schedule and what actually happens are quite different sometimes. So common scenario I get is cat with broken leg, and in fact on examination it's a cat-fied abscess.
Right.
Lamenesses, often due to cruciate ligament rupture or partial rupture. That's a very common scenario in dogs. And puppy and kitten health checks. So when you ask me to think about this in terms of anatomy, and I think about, with our puppy and kitten health checks, we're always thinking about, for example, congenital anatomical problems, basic things like umbilical hernias, or whether they're a cryptorchid or even a hermaphrodite, which I saw recently. So we screen for all of these things all the time without necessarily thinking we're doing applied anatomy. I hadn't thought about that until you told me about the podcast, actually. I thought, oh, yes, I do.
Job done.
Yes. Good work.
Okay, and what about surgery? Are you doing surgery as well?
Right, yes. So I do surgery, and I don't do orthopedic surgery. I do soft tissue surgery, and the most common soft tissue surgery I do is a variohysterectomy. There's anatomy involved in that. Obviously, there's a lot of wound repairs that we do, and they can vary depending on the side of the body. And also dentistry is probably one of the most common things that I do. And when I went to uni, it was not routine practice to have dental x-rays. But since I graduated, we've had this huge explosion in dental x-rays, and thank goodness, because there is so much anatomy underneath the gum line that we need to be very much aware of. So again,
yes.
very useful.
And behind the teeth as well, sort of up in the cranial area.
Yes. Absolutely. Yeah.
Okay, great. So basically you're doing a lot of examination, manipulation, procedures.
Yes, and sample collection too. So venipuncture, cystocentesis, occasionally we do joint taps, and also for dentistry, nerve blocks as well.
Okay. Wow. Okay, that's pretty comprehensive. And I'm getting also this picture that you're not only you're using your eyes and your hands here and your ears as well for
very much
stuff. So it's a very immersive experience. So in that context, if I were to ask you, how important is anatomical knowledge in your day-to-day work? And what I'm trying to ask here is something you've already touched on. Is it like asking someone how they perform a complex yet fairly routine task, like driving a car, for example, where your knowledge is essentially inherent, but maybe a little bit invisible, where you're bringing your skill set to that task with knowing and applying it without even realizing that that's what you're doing? Or is it a little bit more complex than that? So are there certain scenarios where you're applying your anatomical knowledge more explicitly, or maybe occasionally even having to go to the books to check on something?
Yes, well, I will say that we go to the books, that myself and colleagues go to the books all the time. So again, I want to normalize that, because I actually think that looking things up is very useful and important. It's easy for knowledge to drift or one to forget things, and the textbooks come out all the time. For me, my experience is I do tend to think of anatomy at an unconscious level, not necessarily because I've got a great degree of expertise in it, but almost as a clinician, I'm screening for issues. And I am really thinking explicitly of anatomical terms when I am, well, the key time is when I'm labeling radiographs or analyzing radiographs, because it is actually useful to say, that's that's the diaphragm, that's the lungs, all of that sort of stuff, or that's this bone, that's L7. It is useful, but
medial, lateral, all that.
That's right. But on a clinical exam as well. So we tend to sort of label things or put a term to things where it's specifically clinically relevant. The other times when I'm writing referral letters, usually for surgeons, and look, sometimes I'm wrong. Sometimes I'll say it's this vertebrae, and they'll come back and say, well, actually, we did the CT and the problem's here. That's fine. Yeah. But yeah, I think a lot of it is subconscious knowledge, unless I have a particular reason to explore further. I think I have a limited working memory that I need to keep working to supplement. And I was thinking about this in preparing for this podcast, because at times I've had really in-depth anatomical knowledge about specific things. So can I give you a couple of examples?
Please.
Okay. So this is a little, the Australian Veterinary Practitioner, this is a little case report. What's your diagnosis? And it's curvature of the penis in a male-neutered cat with a lower urinary tract obstruction. And I'd never seen this before, but basically this cat's penis is being sort of anchored by a persistent penile frenulum.
Wow.
But I'd never seen that before, and my embryology knowledge was limited. I had this cat who came in with a urinary tract obstruction, and I went to extrude the penis to catheterize, and then thought, what is this bent penis and what's going on? I looked up the textbooks. I actually rang Glenn Shea, who's one of my very good anatomy lecturers, and said, I think I've discovered something. And he said, no, you haven't. So that was a bit disappointing. But we did write it up as a what's your diagnosis, because it did complicate the catheterization. Yeah, and just the process of writing this up in the Australian Veterinary Practitioner, which is a lovely little journal. I'm looking back at this paper, which I wrote in 2016, and there's 10 references. So I spent a lot of time going through, trying to understand the anatomy and also the development of the male cat urogenital tract in order to work out how this happens. And the other example is I was working in a practice, and my boss had, there'd been a cat who had been previously desexed, but there was a problem because they could only find one uterine horn. So they sewed up the cat, sent them home, and said, look, it's probably going to estrus if the other horn and ovary are in there, but we can't find it. And sure enough, the cat did go into estrus. And however, when we reopened the cat, it was all very confusing in there. And finally, we found the ovary and what seemed to be a horn, but it was very different to what we expected. Right. And my boss wanted to throw it in the bin, but I said, no, let's explore this a bit. And
you mean in the clinical waste bucket?
Yes, sorry, yes, correct. Absolutely. I call it the bin, but yeah, there you go. This is my shorthand for things. So I saved it, sent it off for histopathology, and the cat was diagnosed with segmental uterine aplasia, and something I had not heard of before, not really explored. And I looked it up, and it turns out that this abnormality is also associated with unilateral renal agenesis. So sure enough, we got the cat back in to do an ultrasound, and it only had one kidney. And I wrote up this little paper. We wrote it up as a team together, again in the AVP.
I've read that paper, yay!
Yeah, and it was actually, people have read it because they have also done these spays and thought, oh my gosh, what's wrong with me? I can't find this, or there's something going on, or they're confronted with this reproductive tract that is very strange, and they think, oh, have I done something? But actually it's a congenital abnormality. So it was great to write this up, and I read this back and I think, gee, I sound so great on anatomy. But a lot of reading had to happen to put that paper together, and much proofreading and checking with experts.
I love how you've touched on, I think, what is one of the things I'm hoping to achieve by talking to people such as yourself and other practitioners is just to reinforce this idea that anatomy is really your friend, because it helps you to distinguish between normal and abnormal, which is what so much of our work boils down to. You see something, or you don't see something, or you see something that doesn't look right, and just having the ability to judge between normal and normal, or to know, normal and abnormal, or to know whether you need to find out more information. So.
Yeah. Oh, good. Well, to me, that's the story of general practice as well, because knowing when something's wrong, even if you can't necessarily put a name on it, is a very good start, because then you can go and look a bit further or ask someone or find out a bit more.
Yeah, perfect. Okay, so now with that in mind, looking back to your early days as a practitioner, are there any specific aspects of anatomy that you wish you'd had a better grasp on? And by that I mean sort of things like surface anatomy, interpreting radiographs, palpation. There's heaps of other examples probably that you can think of that I can't. Things that might have had a positive impact on that transition from student to practitioner.
All of the above, actually, because it really is the basis of general practice is, and in fact specialist practice as well, is the physical exam. And so surface anatomy is really critical, and palpation, it takes ages to learn to palpate, and of course dogs and cats palpate very differently, so that's something useful to know. And then you've got other species that you don't see as frequently, like your guinea pigs, rats, rabbits. For me, because I work in general practice, I don't see a high proportion of those as someone who, say, is an exotics vet. But also wildlife, how do you palpate an echidna? They're quite different. They're like a ball of muscle, and so at least understanding how to palpate dogs and cats is a good basis for the other things. But all of that stuff is so useful. And I like the way you say anatomy is your friend, because it really is a friendly subject. It's a roadmap. It helps you understand disease processes and localize disease processes so much better. And actually recently I've met a wonderful colleague who is a friend, Andrew Gardner, who wrote a lovely book. He co-wrote that, and I've ordered a copy because I feel instantly more curious about anatomy when I meet someone who's a friendly anatomist who's not going to judge me for not knowing the name of this vessel or that muscle. If I don't feel intimidated, I feel like I can approach something a bit better, and then I'm more curious about it. So one area that I think would have helped a lot is, I guess, anatomy of the forelimb and hind limb. I think if I had those in a bit more detail, particularly of the dog, because lameness is just so common and it can be really tricky to localize. The wonderful thing is, of course, they have 4 legs, so you can at least compare one front leg to the other. But when you've got bilateral disease, that's where it becomes really tricky.
Yeah, I'm thinking about neuro coming in here as well.
Yes, absolutely, yeah.
I'm sort of getting you to bounce back and forth between different stages of your career, but where you are now, is there any, an anatomical curiosity or aspect of anatomy that you would like to explore further at the moment?
Yeah, well, I'm actually really again, going back to Henry's comment about vet school being wasted on vet students, and that's not a criticism of vet schools. I think it's just the way people learn. And for me, it rang true. For others, it might not. But just going back to that, I actually feel like wanting to go back to those basics and just getting a good overall picture. So things that I felt like I didn't really have a grasp on were the anatomy of the nervous system, the anatomy of the blood vessels, and they are particularly useful and important things to know. But also, one of the things that I've done since uni is specialize in animal welfare science, ethics and law. So I'm registered as a specialist in Europe, but not in Australia. I should be clear about that. And there's anatomy comes into animal welfare issues as well, particularly with breeding. Again, dogs are a great example because we've had this boom in brachycephalic breeds all over the world. And of course, they've got stenotic nares and hypoplastic tracheas, and they can come to have inverted laryngeal saccules. And there's all sorts of other things. They're at more risk of hiatal hernias. And quite a lot of them have intervertebral disc disease. So all of these things, again, have an anatomical basis. And you really need to know a bit about anatomy to understand what's going on, to explain it to owners, and to be able to manage those cases.
I remember reading a paper in, I can't remember which journal, which for the first time that I read that brachycephalic dogs have 30% of the nasal volume of mesocephalic dogs, and being just blown away by that figure. And then this idea also, because they have the hyperplastic scrolls in their noses that go back into their nasopharynx, that breathing in is like sucking too hard on a straw. It just draws the sides of the mucosal surfaces together and actually obstructs the airway. And so, yeah, that's that anatomical anatomical perspective, if you like, really brought it home, the welfare implications. And as
and
you
then
say,
you can see that leads to this mechanical problem in respiration, and therefore leads to air hunger, which we know is associated with fear and anxiety and distress. We know that these dogs have lower oxygenation, they have a lower reduced lifespan compared to other breeds. So it all makes sense. But quite a lot of the time, we're just looking at an animal from the outside without, well, in general, people, looking at an animal from outside without that anatomical understanding. And when you can explain that to people, it does have an impact and potentially changes human behavior and might help these dogs in some way. Every dog, every animal deserves great welfare. So I think we've got an obligation to provide that for every animal.
Look, I think that just about wraps it up for today. I just want to say thank you so much for your personal perspective today, and for bringing that such a practical approach to a subject that can seem overwhelming and a little bit drier, even potentially in those preclinical years. I just wondered, before I let you go today, for students who are watching this, say, just about to commence their veterinary studies, getting towards the end of their veterinary studies, maybe have just started their career as a veterinarian, or maybe you're even mid or late career vets, would you have any parting nuggets of advice from an anatomical perspective that you'd like to leave us with today?
Gosh, well, I think I'd have to sort of focus my answer around the learning process, because I found that so difficult when I was going through. And what I would say is, if you're really struggling with anatomy, just start with one aspect of one case, whether it's looking at a radiograph or analyzing a case about your own animal, and just try to focus on exploring in depth one thing, because the great thing about anatomy is everything is connected. So when you look at one thing, everything else starts to become relevant and make sense. So I'm super excited about the other podcasts that you're going to put together, because I think they're going to be such a lovely, warm and engaging, friendly way to discuss anatomy. So I'm personally going to benefit from those quite a bit. So my other tip is listen to Corinna's
Oh, well, thank you very much.
Pay me to say that.
Thank you very much.